home during the COVID-19 pandemic. My dog is down here too, so if you hear some barking, that is her, not me. Here's what I'm going to do. I'm going to do this lecture in 4 YouTube videos, each of which is going to be about 15 minutes long because that is my attention span for a YouTube video, frankly. And I'm going to cover first the history of public health emergency management. Then I'm going to talk about sort of the current legislation and structures of it. Then I'm going to do a deep dive into COVID and some of the failures and successes of that response. And finally, I'm going to spend a little time talking about public health ethics and how we do decision making in public health emergencies and why that is complicated. I'm going to be referring to a set of readings that I gave to Professor Shapiro, and hopefully you've had a chance to check them out. That's what I got. I'm not going to lie, it's a little weird for me to do a lecture without anybody in the room with me, without being able to take kind of questions or discussion. So if you've got them, feel free to drop me an email or anything like that. A little bit of background on me. Again, my name is Mitch Stripling. I've been a public health emergency manager for more than 15 years now. My first disaster was Hurricane Charlie back in 2004 in Florida. I'm currently the National Director of Emergency Preparedness and Response for the Planned Parenthood Federation of America, which encompasses more than 600 clinics around the country and more work globally. Before that, I was the Assistant Commissioner of Agency Preparedness at the New York City Health Department. Before that, I worked for the state of Florida. So I think that is about enough background. Let's dive in. So for this first lecture, I'm not going to have any visuals or anything. I'm essentially going to tell you a little bit of a story. I'm going to assume, since this is an emergency management class, you're getting some of this stuff about Quarantelli and the Stafford Act and where emergency management came from and ICS and wildfires and all that kind of stuff. So I'm going to just let y'all handle that. Here's what I'm going to say. For the first few decades of this, public health response was like fully separate from emergency management in general. In fact, public health response is in some ways older because even before the 1918 pandemic, there were outbreaks of cholera. There were other infectious diseases like measles that tended to kill a lot more folks than they do today. In some respects, public health plague response goes back hundreds and thousands of years. The Black Plague, the plague of Justinian, the plague of Athens, back into recorded history. But it was always considered sort of a special case, and it was never done with the same kind of response mechanisms that you see for an earthquake or a fire or a hurricane or anything like that. And that began to change. Actually, the prehistory of this is in the 1990s when Bill Clinton, who was president of that at that time, I think this is a true story. I'm pretty sure the research checks out. He was on an airplane and he read this book called The Hot Zone, which is kind of a potboiler nonfiction book about Ebola almost escaping into the United States. And he was so terrified on the plane ride that when he landed, he founded the Strategic National Stockpile, which is a stockpile of medications and medical supplies that can be drop shipped anywhere in the country within 24 hours. Still in use today, saw a lot of service during COVID. But that was kind of the initial sort of bioterror push in the country. And then later in the 1990s, we saw some initial biological weapon legislation as the late 1990s threat of Al-Qaeda came into play. But the real sort of history of public health emergency management, as we now understand it, really starts after 9/11 with the anthrax attacks of late 2001, Amerithrax, it's called sometimes. It killed 5 people. It infected another 17 folks. There's been a long-running FBI investigation that landed on, eventually after looking at Al-Qaeda as a suspect, looking at some other Americans, landed on Dr. Ivins, a laboratorian in military service, as the culprit, although there's been a whole bunch of work on that investigation. I'm stumbling a little because it's kind of a fuzzy story. You'll have to check it out yourselves. Anyway, it killed Americans and it caused a lot of terror in the country because there's also biological warfare capability that was out of Russia, that had been sort of misplaced in the fall of the Soviet Union. There were other state actors like Iran who certainly had the capability of biological warfare. And you had people like Al-Qaeda, other terrorist cell organizations, even some domestic agents who had worked with various degrees of success in biological warfare. So after anthrax, an initial set of legislation came out that founded some initial principles of public health response. Now, the lens I'm going to use to tell the story is the lens of CDC, coming from the article that Dr. Frieden and Dr. Red wrote about the evolving approach at CDC to emergency management. What anthrax did was it helped CDC realize how atrophied their muscles were about emergency response. In anthrax, there was a New York City cell because there were letters filled with anthrax spores sent to media personalities in New York City. There were letters filled with anthrax spores sent to Congress people, sent to senators in Washington, and also there were some sent to media headquarters in Florida. So you had 3 states that all needed coordinated epidemiological results along with countermeasures for anthrax, which are pretty intense. You had multiple doses of high capacity antibiotics that were needed there. And CDC realized that they didn't have the coordination capability to handle it. So in the initial round of legislation, you saw some initial things that were created in what's called the Pandemic and All Hazards Preparedness Act for CDC. You had CDC's first Emergency Operations Center created, the first Public Health Emergency Operations Center that I know of that was built on EOC models from ICS, from FEMA and other kinds of models like that. You had a program called the Public Health Emergency Preparedness Program, which was a grant-based set of aid to states for states and localities to build up their public health response system, to similarly build EOCs and that sort of stuff. You had a massive expansion of the Strategic National Stockpile, founded by Bill Clinton with the nonfiction book that I just talked about. And you had a new set of laboratory regulations because both of how anthrax was disseminated and also other concerns about other diseases, like we would see later with SARS, a little bit later than that with MERS, a big concern was the escape of a pathogen from laboratories. So there was a new laboratory response network that was set up along with guidance on various what are called BSL or biological safety levels at laboratories, BSL 1, 2, 3, with the higher numbers indicating more secure laboratory surroundings. So all that was kind of kicked off as part of the anthrax response. And a massive reason for all of that was simply the volume of information. We're going to see this over and over when we talk about public health emergency response. There was so much information coming in, lab samples, as well as sort of doctors' diagnoses, as well as all the stuff in the media, that the CDC was finding it impossible to process that level of information. The tracking of a patient to a numbered ID lab sample to an epidemiological report, which was sometimes different than a medical report on that patient, linking them all into a unified story was beyond the CDC's capability at that time. And because the globe was getting more and more urbanized, there were more cities connected by air travel, the CDC was more concerned, rightly so, about both biological attacks and natural diseases. So those sorts of capabilities were started in 2002, 2003. Now, Hurricane Katrina was a wake-up call in that it showed the level of public health threat you might see from an issue like a hurricane. I worked on Katrina from a health perspective, and I'll tell you that things like dealing with the decomposition of bodies, dealing with stopping outbreaks in shelters, dealing with making sure that people had appropriate environmental health considerations for dealing with waste, that evacuations were handled in safe ways from a public health perspective, making sure that people have adequate medical surge. Those kept us up, running 24-hour shifts for half a year after Hurricane Katrina, because they were both severe and because no one since Hurricane Andrew had thought about or codified those things. So a whole bunch of public health lessons had been lost simply because there weren't response entities to kind of listen and consolidate that stuff, right? So that sort of took this to a new level. And after Katrina, as you know from the emergency management side, there was a post-Katrina Emergency Management Reform Act that tried to sort of centralize and unify some of these capabilities, bring public health more into the fold with emergency management for a more whole of government response. All of that then got flipped on its head in H1N1 in 2009. So if there's one incident that shows a lot of the kind of DNA of the COVID response, although at the time it was regarded in a much stronger way than the COVID response is right now publicly, it was that H1N1 response. Now, if you remember that in the spring of 2009, there was an outbreak of a new influenza in Mexico. It was believed to come from farm animals into a set of children in Mexico at that time. That's why it was called the swine flu. It shows one reason why diseases are named more scientifically now, right? That's why COVID-19 is COVID-19. It's because people tended to name things like swine flu, although it didn't have anything to do with pigs, and it led to the unfortunate slaughter of a lot of pork in 2009. Anyway, it left from Mexico into the United States via some kids from New York City who had gone on a field trip there. I was working in New York City at the time, and what we saw in 2009 were kind of two big waves. There's a spring wave of H1N1 and then a fall wave, and the epidemiology showed that that might be a massive, deadly pandemic, and it ended up not being as deadly as regular seasonal influenza, although it did focus on and kill different vulnerable populations. And so for that reason, it did cause a lot of mortality. Now, at that time, CDC was able to stand up the EOC that they had started working on in 2002. This was the first massive emergency operation that CDC was coordinating and not just supporting. Since then, by the way, the CDC Emergency Operations Center has been mobilized 99% of the time. That's the number of pathogenic threats that have been circulating in the last decade. H1N1 was also the first time that PCR tests were utilized widely in a pandemic. So PCR, polymerase chain reaction, that's kind of the laboratory workhorse test. When you hear about a COVID test, for example, and it takes 48 hours to turn around, those laboratory tests were kind of pioneered at scale during H1N1, and also rapid vaccine production. So H1N1 also was able to test the countermeasures muscle that CDC had built up. They were able to create and disseminate 81 million doses of H1N1 vaccine within a year in a very short timeline. So when they talk about a vaccine timeline taking 3 years, 4 years, something like that, doctors are talking about a new pathogen. H1N1, because it was an influenza, was able to use the existing infrastructure for vaccines, so it could happen a lot quicker. After the H1N1 response, 59% of the country rated that response good or excellent, which is a little hard to see these days. And it's important that part of what the CDC started doing during H1N1 was training incident commanders. So the way the CDC incident management structure works, anyone sort of who's a leader within the CDC, the Centers for Disease Control, can become an incident commander if an incident kind of falls within their capacity. And then the public health emergency managers sort of come in and support those folks, help them to be leaders. CDC realized that they didn't have a lot of strong sort of response style leaders on their bench at that time. So why is that? It's because the CDC decision-making process and the decision-making process for public health in general is often very consensus-driven, right? Everybody wants to agree and they want to come to one unified decision, the way you do when you're writing a paper, right? Or the way that you do when you're doing medical grand rounds. That style of decision-making, unfortunately, wasn't appropriate in H1N1. The CDC, to their credit, realized it. I actually remember one of the first lectures that I ever went to in New York City when I started working there was with an NYPD Deputy Commissioner of Counterterrorism who used to work in the Bush administration. This was before H1N1, and he said something I've never forgotten, which is no doctor can be an incident commander. He was asked the question, in a pandemic, who should run the response? And his opinion was that emergency management or the NYPD, somebody like that, should run the response simply because doctors did not have the ability to lead in that way. CDC also realized that same problem. They took a different approach, which was, well, let's train them. Let's give our medical professionals the tools they need to do that. And at this point, they've trained dozens and dozens of their senior leaders who are ready for that challenge to be taken on. The next kind of growth step in this story came about when Ebola happened in West Africa. So in December of 2013, an 18-month-old in Zaire was bitten by a bat. And that 18-month-old became the index case for a massive outbreak of Ebola that would last 2014, 2015 into 2016, really almost 3 years of time. At the end of it, it would kill, where's my stat here? It would kill 11,000 folks. It had 28,000 cases in total in 3 countries in West Africa. So at the time, that was one of the most major public health incidents that had happened globally in 100 years. And there was real concern that it would spread to the United States. In the end, only a very small number of returning travelers to the United States, I think 2 folks, came in and were treated with Ebola. A couple of other people were flown back medically, knowing they had Ebola to be taken care of at specialty hospitals. And our hospital system was able to contain them with special isolation wards. But there are a few things about it that were really important. When Ebola happened in West Africa, it wasn't a novel disease. People had seen Ebola before. However, the typing of that disease was novel. There are various strains of Ebola, and typing it was a problem because you had to understand what kind of Ebola you were dealing with, to understand sort of what your treatment options were going to be, to understand what your case fatality rate was likely to be. But because of a number of hostile forces in those countries and a lack of confidence in medical guidance, a lot of the population in those 3 countries was actively hostile to both World Health Organization doctors that would come in and later CDC doctors that came in. You've heard of the CDC Global Health Agenda, or the White House Global Pandemic Team that President Trump famously shut down in office. Those came out of this idea in Ebola that we needed a global presence in order to keep things like this happening again, to make sure that we could both contain outbreaks at the source, but also that our medical professionals could be kept safe and could kind of give the guidance they needed to give in any kind of global outbreak. So what did CDC learn? So in Ebola, CDC learned to use incident management teams in rotating ways at that time because it just went on so long. They had to sort of rotate through thousands of experts in different fields, countermeasures, epidemiology, all of that stuff. They also developed and perfected the test, trace, isolate technique. Again, this is something that we've heard a lot about in COVID. The idea is that you test folks for Ebola. When you get a positive test, you want to do contact tracing. So everyone who is a close contact of that person is traced and they are tested as well. If they're positive, then they're isolated to make sure they can't infect anybody else. By doing that kind of test tracing and isolating, that public health work is actually what eventually brought the Ebola outbreak under control, because you were able to do eventually, once you had sort of better treatments for Ebola, you were able to do sort of ring testing, and you could capture and give some initial treatments to a ring of folks around a known cases. And when you can do that, you can put a bulwark in place to keep an outbreak from spreading. So that was a deeply sort of important skill CDC learned. Another thing was airport screening. One of the first actions that was taken when Ebola began to surge was returning traveler screening from the West African countries that had Ebola. It was set up in, I think, under 72 hours at 5 major airports at first that had a lot of returning passengers from those countries and later expanded. And it really became a test case for what was done in January of 2020 in terms of screening passengers who are coming from certain countries and then tracing them, if they had symptoms, or making sure that you could do monitoring of those passengers. The musculature for that was built during Ebola, then kind of put in a box and then pulled out quickly when COVID happened. The other real lesson learned, and we're going to talk about this next lecture when we talk about hospital preparedness, is the idea of hospital surge and hospital isolation areas. Now, when Ebola happened, there were a lot of healthcare grants that came into play. Because remember, for Ebola, we're talking about 3 years. We had 2014, 2015, 2016. And even though most of the fear and cases in the United States were clustered in 2014, the outbreak went on for a while. We realized at that time that, excuse me, hospitals in the United States did not have the infrastructure in place to isolate patients the way they needed to. And so the federal government put out a number of grants to enable hospitals, all hospitals, to be prepared to receive and screen Ebola patients. And then for a certain number, fewer hospitals, to be able to take in Ebola patients, isolate them, and take care of them with certain features like negative pressure rooms and special equipment, specially trained staff, all that sort of thing. So that was built out in Ebola, and again, was ready to be used at the beginning of COVID when we were talking about a few cases here or there. That musculature was really important in being able to isolate those patients, diagnose them before we knew really what we were looking at in terms of COVID. So after Ebola, the last piece in the story before COVID that I want to talk about is Zika. So in 2016, just as Ebola was fading globally, a new sort of set of symptoms of concern started showing up. That was babies in the Caribbean and South America, in some cases, who were microcephalic, meaning that they were born with small heads and had brain damage, in really a tragic set of circumstances. Scientists were confused about what it was at first, and then they were able to link it to the Aedes aegypti mosquito and a virus called the Zika virus. Now, this was a surprise because the Zika virus had been kind of shuttling around down there for decades. People had known about it, but it had never caused symptoms like this. So whether this was a viral mutation or some kind of environmental factor, epidemiologists weren't really sure, but they did start seeing more and more microcephalic cases. And it was scary for another reason, which was a lot of the cases of Zika were asymptomatic. You couldn't tell who had it, but it led to this really tragic outcome in some cases, right? Because it really only impacted pregnant women. This is terrifying, right? When you can't track a disease, when you don't know who has it and who doesn't, it's very difficult to know what to do about it, how to trace it. And so it really built up at CDC this new range of diagnostic specialties. The idea that you needed to, viruses were going to adapt, you needed to adapt with them. You needed to really focus on risk communication. What a tricky message this is, right? Here's a virus that won't hurt most folks, but if you're pregnant, could cause tragic consequences for your baby. They had to do a lot of outreach to special populations, people with roots in the Caribbean and South America. And it became a real sort of a humbling experience for the public health community in terms of risk communication. Messages weren't getting through. People did more and more sort of clinic outreach. Eventually, were able to sort of tune the messages that they were using more towards the populations they needed to reach. But it took sort of months of effort. And the CDC started doing a lot of study of what that was and why. So that's kind of the major history, the sort of beats of what happened in the development of public health emergency management. And it's helpful when you look at that journey to see that public health has spent a couple of decades building up some muscles that are really inherent in emergency management more generally: collaboration, coordination, risk communication. But there are also some things that are special within public health that need to be treated differently. Diagnostics, laboratory tests, medical countermeasures, hospital surge are things that were really new capabilities that needed to be built up that people on the emergency management side didn't necessarily understand. So what you saw develop over time was public health emergency management as kind of a separate sort of a sibling of classic emergency management that was fairly similar in terms of some incident command practices, but different in others. Still more collegial decision making, still deep ties with the medical community, but trying to build up the technologies you get in a well-functioning emergency operations center. So at the end of it, CDC, this was just before COVID, 2017, 2018, published sort of a set of 7 lessons of what they got from this. Experience matters. You really need to have people that are ready to lead in these areas, not just with medical knowledge, but with deep decision-making skills and abilities. They needed to be able to lead people. Much better to use and surge routine systems that were already in place. CDC and H1N1 used a system called the Vaccine for Children system to disseminate H1N1 vaccine, those 81 million doses. On the other hand, antivirals that they disseminated to help with the treatment of H1N1, they sent out through a new set of systems that each state developed on their own. At the end of the day, CDC felt that disseminating through an established program was much better because it was trackable, it could be prioritized to people that needed it most, and it was the same state to state, whereas the antiviral dissemination they felt like was chaotic, leaned into the private sector. A lot of folks who could pay more money ended up getting antivirals even when they didn't need them. Third, it turns out that bioterror isn't our biggest threat. Natural disease outbreaks are our biggest threat. Because the world is getting more globalized, it's the natural stuff that's going to get us. Fourth, you've got to be improvisational in public health emergencies. This is a big lesson from the history of disaster sociology. Quarantelli, Jim Kendra, Trisha Wachtendorf and others have talked about the improvisational nature of emergencies, right? That's hard for doctors. I will tell you as a non-doctor myself who works with doctors, because what they want to do is diagnose and sort of follow a procedure guide. In an emergency, there are too many complex factors that are happening. You can't just look at one patient. You have to look at all of these complex interactions that are happening with risk communication, political pressure that you're getting, the outside people that don't understand science who are pushing on you to do one thing or another. A good example of that is this airport screening. Airport screening isn't something CDC ever thought was a particularly good idea. The received wisdom in the epi community is that airport screening really is only going to help you maybe for 2 or 3 weeks at the beginning of a pandemic. But politically, they received pressure to do it during Ebola. They did it, and it ended up that it helped them to actively monitor travelers that were coming back. It became part of the playbook, although there's still not great science that it's helpful in the long term. But they were able to do it and adapt and put it in place. And by doing that, they kind of realized, hey, we can do this. We can adapt even during emergencies. We don't have to have built every playbook ahead of time. Fifth, risk communication is really the key in a public health response. In public health especially, because these tend to be longer lasting responses than a hurricane or an outbreak or an earthquake, something like that. A public health pandemic takes months, years to play out. That gives enough time for a whole ecosystem of disinformation to come into play. Obviously, with COVID-19, we've seen that with the fights about masks and other things we'll get into in the third lecture. But even during H1N1, during Ebola, we saw tons of disinformation being lobbied globally at the medical community. People thought that doctors were bringing Ebola to West Africa. People thought that the H1N1 vaccine was a tool by the government to control communities. This always happens. And CDC realized they had to get much better at risk communication to deal with it. In particular, you always had to sort of say what you knew, what you didn't know, and you needed to trust your audience, to be adults, to deal with all the information that they've got. So we'll see the successes and failures of that being COVID a little later. Sixth, public health responses can't be done in isolation by CDC. Early on in H1N1, CDC really tried to control the whole kit and caboodle of what was happening. They learned quickly, just like in emergency management, you really have to coordinate across all of government to make something like that happen. In Ebola, the Department of Transportation controlled certain waste protocols. They really had to take on the mission of transporting Ebola waste across state lines. In something like Katrina, obviously public health is one part of a larger response system. In Zika, because it dealt so much with pregnancy, early childhood, health department really had to work with a lot of early developmental experts to look at how severe the symptoms might be for kids. All of these things are whole community collaboration and coordination, writ large issues. So finally, and I think in some ways this was the hardest lesson for the doctors and other public health practitioners, the urgency of a disaster always means that you've got to act with incomplete information. And you could say, well, obviously, but the way that the public health guidance works, they're used to looking at something like tobacco, cancer, heart disease, the polio push in the 40s and 50s is a good example. Decades-long struggles where the science can really define the optimal strategy, and you can put in place an optimal set of measures to meet that strategy, where you've got years to develop treatments, you've got years to develop vaccines. Working under emergency conditions, you see the CDC time and time again fail because they need more time. They want time to get a process just exactly right. They want time to get guidance just exactly correct, when what you need in an emergency is 70 or 80% good enough, get it out the door so you can move on. I remember that just starting to work in both Florida and New York City, there's a system CDC uses called the Health Alert Network to push out emergency messages to providers. Except that oftentimes in an emergency, the epidemiologist would take so long writing down the nature of it that a day or two would pass before any emergency information would get out the door. By that time, there had been 20, 24 news stories out there. The narrative had been set, and all the CDC could offer would be, a little update to existing guidance. Nobody really took it seriously. So being first, being right, being credible really became the mantra. This isn't an American problem, by the way. One of the most noted bioterror attacks of the 90s was the sarin gas attacks in the Tokyo subway system. Same thing. People were being rushed to hospitals. People were being treated at hospitals. Doctors were calling each other, noting that this was a neurotoxin gas that was being talked about. It wasn't until maybe 10 hours later at the end of that whole cycle that finally the Tokyo Health Department put out guidance saying sort of what the agent was and how to treat it. By then, it was too late. So in closing, the summary for this is emergency management is not a capability that comes easily to the medical profession. People want to control their patients. They want to control the narrative. They're uncomfortable letting pieces of this go. They're uncomfortable working in an improvisational emergency operations centered fashion. But they've learned at each of these steps, systems have learned and they've gotten stronger and they've gotten more in place. Next time, we're going to talk about where that development led to, what the systems are that are in place. And then after that, we'll talk about COVID and how it basically got thrown out the door, but in ways that hopefully are productive for future emergencies. So thanks for watching this one, and I will see you in the next lecture.